Hello, everyone. I am so excited to be here tonight and so excited to get to give this topic. So, when Mindy reached out, she had given me a couple topic ideas, and instantly I'm like, of course, let's talk about sex. It's like one of the best songs ever made. And we never talk about it in clinic. We all have had it at some point, most of us, or think about it, or read books about it. Fourth wing, anybody? And at some point, for most of us, we may have struggles with sex or symptoms around that. And in particular, both with non-neurological and neurological symptoms or patients with neurological disease. But it's something that we often don't talk about. We certainly don't get much training in medical school, maybe a couple of days. So it's something that if you're challenged by it, you may even bring it to your doctors if you're so bold to do so. And they may not always be the first best resource to help you. They may want to, but they may not know how to help you. And that's a tricky spot to be in because these are the people that are there to help you. And when I spoke about this topic, I was often met with either, aren't you going to be embarrassed? That's such an embarrassing topic. How are you going to talk about this? Which I thought was so perplexing because if you know me, I love to talk. TMI, like I always overshare in clinic. I ask way too many personal things that are not pertinent but are interesting to me that I want to know about. So I was not worried about being embarrassed. But most people ask me, would I be embarrassed by this or find this embarrassing? But that was not a concern of mine. A few people, though, thought it was a great idea. But definitely, I could see interest, and definitely a lot of people, more than ever, took flyers. Like, flyers come for talks, and sometimes they get touched. This was the one that every person took the flyer. Every time. And that I knew said something. Because those flyers went. I saw them peeking out of the bags. Even if someone didn't ask me about it, I saw that a flyer was taken for this one. But through my research, I also had my own kind of journey preparing for this talk because it taught me a lot about myself and how I don't do a good job asking. So I'm readily putting myself out there as someone who has not done a good job with my own patients, asking enough and managing enough. I learned a lot, so I'm happy to share with you the things that I learned. But I will also tell you that in my research, a lot of what I learned did not come from MS specialists. It came from other disciplines who have done a lot of the research and have paved the way. So I also think it showed me that we have a lot of work to do in the MS community to really be more proactive, doing more studies, getting more treatments, understanding this more, and talking about it more. You know, I think we could do better, and it certainly opened up my eyes, and I look forward to talking about this more with my patients, tackling it more, and seeing, you know, what more we can do. So, if you have not picked up on it, I do like to talk. Haven't even gotten to my first slide yet, but we will get started. All right, top button. So, polling, a couple of questions. So, first question. Who in here has ever, and this is for MS and non-MS people, just people in general, who in here has ever had a doctor ask them about sexual function? All right, so I see at the tables maybe 1 or 2 hands per table, right? So probably less than 50%. Who in here had to be the one to ask their doctor about their sexual concerns? So maybe they had concerns, but they had to be the one to really raise it to the attention. So I see some scattered hands. Ha. And who, after they were discussing these issues with their doctor, felt let down by the encounter? Who felt like they got a good solution to their encounter? Who felt like it was really managed well? I see 3 hands, 4 hands maybe, and I see hands that went up for being let down. Okay. What I don't see is a sea of hands who discussed their problems and a sea of hands who felt like they were well managed. But the statistics would say that a fair amount of us are not 100% rocking it with our sexual health. And for a variety of reasons. And it's complicated why we don't talk about it. And it's complicated why it happens. But I think that is in part why I was so excited to approach giving this talk. So first thing I wanted to go over is intimacy. Because I led with sex, but really intimacy, right? So intimacy, what is that? It's a feeling of a deep, meaningful connection. And it's where individuals can be authentic and vulnerable without a fear of judgment. It creates a bond that feels safe and supportive and secure. So, how you build intimacy? You build it through vulnerability, open communication, and shared experiences. And I bolded the open communication because that is really that core theme that's going to run throughout this topic. Communication is of utmost importance when you're trying to navigate issues around sexual dysfunction and how to plan for it, how to talk about it, how to diagnose it. And these are hard things to talk about for a lot of people, but I think the communication is really critical here. And when you can't talk about what you're feeling, how you're feeling, what your body is feeling, it is much harder to successfully navigate some of these roadblocks. Because a lot of it can be navigated, but I think it starts with knowing your body and knowing your feelings and having a safe space to have that communication. You can have intimacy or ways to build it, I will say. So if you have a partner and you're not feeling so intimate with them, because intimacy is not sex. There may be sex with someone that you are feeling intimate with, but they are not synonymous. So ways to build that intimacy if you feel like through the course of having MS or just in general, right? Like you are stressed, you are busy, you are running a household, you are doing all of the things, and you are feeling disconnected from your partner. You are feeling disconnected from that support. Or maybe you are feeling like a burden to the person that is helping to care for you, and you are losing that partner-partner relationship, and it's starting to feel more like a caregiver, burden relationship, whether both parties feel like that way or just one side of that party. But you want to work on that intimacy, ways to build that intimacy. I think you can let that person back into your world more. So sometimes we get so focused on ourselves. or we sort of wall ourselves off. We don't always work to let someone else in. So making an effort to let that person into your world, being intentional and dedicating more time to that other person in your life to build that intimacy, trying to care about what the other person likes. So my husband likes things that are not of my interest. And I have to remind myself, try to ask about the things he is interested in. So I try. He had me watching like the Formula One, but like the French racing league of race cars, and I tried. Sharing values, discussing spiritual beliefs, and exploring physical boundaries, but at a pace that you're comfortable with. I think sometimes, if every time you try to snuggle, it turns into, one partner wanting more than the other partner wants, that can lead to one partner being like, I don't even want to initiate snuggling because it's going to turn into a fight, because it's going to, one's going to want it to go one way. I'm not going to want it to. So I'm going to cut that off at the head, and we're not even going to engage. So I think if you have that open communication and set boundaries of like, this is just snuggling, it is not going to turn into more, and set that communication, it allows snuggling to be snuggling, or holding hands to be holding hands. Sometimes building up to bigger physical intimacies really to start with smaller, and sometimes you really do have to take those baby steps. But I think being intentional in setting those baby steps goes a long way in rebuilding that intimacy. So examples for people who forget what it was like building intimacy when you were like 10 and just starting. So the small things. So cuddling, hugging, kissing, holding hands, massage. Sexual intercourse is when you were older, not 10, obviously. But some ideas of ways to be both intimate, physically and non-physically. So, moving on. Now we'll get into some fun things. So the neurology of sex. And I found this really cute graphic of a brain and a heart that I thought was really good. So this is really, really kind of fun to think about because so much is involved. It is really a complex interplay of central nervous system, peripheral neural structures. So you have your brain, your spinal cord, but you also have your peripheral nerves. So you have your motor nerves, your sensory nerves, your autonomics. And then you have your higher cortical processing. So that's like your judgment, initiation, decision-making, right? All of it is all involved in sex. So this is not all of it, but these are just kind of some fun areas that I pulled out to highlight as parts of the brain that are involved in sex. So hypothalamus, might have heard of it. It helps regulate our sexual behavior. It has a role in the autonomics, so that's things like our pulse rate and our blood pressure during sex. It produces hormones that affect our sexual function. Thalamus is a relay station between our spinal cord and higher levels of the brain. So it's sort of this like erotic relay station, you can think of as. The amygdala, that gives us emotional significance to stimulation and modulates our sex drive. Hippocampus, that got cut off, but that is memory. Like, oh, I remember that partner was great, or that partner was terrible, or that partner, smelled. So maybe skip that one. The orbitofrontal cortex is decision-making and initiation and impulse control. So say you're on a medicine that turns up impulsive behavior. right? Maybe now you're making decisions that you wouldn't normally make, like gambling or overconsumption or, hypersexuality. Or say there's a scar there that changes and decreases activity in that region of the brain so that you are feeling less sexual than before, right? Each of these parts of the brain has a job to do. And an MS scar or a medication can really regulate or change how these regions are all interacting and can have a downstream effect on sexual behavior. So, all of these parts all work together, but damage or medications or even stress, exercise, all influences how these work. The insula, so that allows for that self-awareness of bodily sensations. Cerebellum helps with that like fine motor control or coordination. Parietal lobe, sensation processing. So all of these regions play a part just in the brain. And the brainstem, right? So brainstem, spinal cord. Brainstem is really connecting brain to spinal cord, but it plays a part in autonomic functions related to erection and ejaculation. And this just lists some of those centers that are involved. But if you have scars there, that may impair that ability to get an erection or get an ejaculation. And then midbrain has a big part with sexual drive and pleasure. So again, scars there, damage there can change some of those feelings for a person, right? So a partner may take it as they don't like me anymore. They're not interested. What am I doing? It may have nothing to do with them. It may have everything to do with the scar that is sitting in that region. And maybe that scar is secondarily causing spasticity or painful pins and needles so that when that leg gets touched, it spasms and it burns, and that makes things so much harder now to figure out. Not impossible, but harder. So, these things are not always so simple, but not impossible. So spinal cord plays a part with tumescence. I think that's one of my new favorite words, by the way. Tumescence, lubrication, perineum contractions, and it's a relay station between the brain and the genital nerves. And there's a couple different ways that people can get erections. So the first is erections by touch. So for this, the sensory nerves in the genitals will transmit signals to the spinal cord upon physical stimulation. And this will activate neurons in the lower spinal cord. And the sacral parasympathetic nerves will then cause some changes in the body that ultimately draw blood into structures, either the penis or the clitoris, that lead them to engorge or get larger. So either an erection or the clitoris will get a little larger. And then with that, you'll get lubrication, either prostatic fluids or vaginal lubrication. So this is like a reflex arc. So this doesn't actually go up into the brain. This stays completely lower level. But you can also get an erection by thought, right? So watching a movie, thinking about something, that's a different way that you can connect and get an erection. So this uses a different pathway. This is where thoughts in the brain travel down through that cord to the thoracolumbar plexus. So with this one, that ability to have feeling kind of around that kind of lower pelvis area, if you have preserved feeling down here, you are more likely to be able to still maintain an ability to get an erection by thought. So if you were someone who had a profound injury in that area, that might be harder to achieve. Not impossible, might be harder. Now, as far as orgasm and ejaculation, right, because each part is something different. A lot of neurology in all of this. That's why the brain's the best. It just does all kinds of fun things. But basically, with an orgasm, you're having activation of multiple pleasure centers in the brain, but you're also deactivating certain centers. So you're like letting yourself go, quite literally. You are turning off certain centers, turning on certain centers, and letting your brain go. This picture here is a graphic that shows areas of activity during orgasm. And so you will see, quite literally, multiple regions that light up during. It's not localized to one small region. It is a vast network of activity during orgasm, which is pretty awesome. So sometimes people will say, if I have no genital sensation, can I orgasm? Orgasm is a brain thing. So yes, you may not have good sensation in the genital region, but the orgasm itself is an inside process. So not being able to have sensation generally doesn't mean that a brain can't orgasm. It may mean it's trickier to figure out how to trigger it, but it doesn't mean it can't happen because it is an inside process, not an outside process. So just want to put that out there. So as far as ejaculation, for that, you have a different part of the neuronal pathway. You have a segment in the spinal cord that has some special neurons called the spinal ejaculation center, which project to neurons that initiate expulsion. So those are what complete that. So sexual dysfunction from MS, it gets divided into 3 categories. So you have, let me see if this, okay. So you have primary, secondary, and tertiary. Primary, so these pictures here are going to reflect your primary, which is dysfunction because of damage directly to centers that had jobs related to like sexual regions in the nervous system. Secondary is because of physical changes from MS. This was my example of like spasticity, right? Sometimes this muscle can get really tight, bring the legs really close, and that could make things harder. And then third is more cultural, psychosocial, like some of those challenges that can then influence things. So primary dysfunction, so that, like I said, is those changes from direct damage to the nervous system itself. That can cause things like a partial or total loss of libido, unpleasant or decreased sensation in genital tissue, decreased lubrication or erectile capacity, or decreased frequency and or intensity of orgasm. Secondary dysfunction from MS-related changes. So that might be bladder or bowel, fatigue, weakness, numbness. This is a partial list, right? MS can do a bajillion things, but this is just some of the more, common ones that people would tell me about. And then tertiary, also a big one. Probably the one that I am least an expert in, but I have a table of brilliant people who will be joining me that are experts in a lot of this stuff. But things like this, right? So less self-esteem, anxiety about body changes, beliefs about what it means to be sexual or like sexy in society. So how do we know that someone might be having sexual dysfunction? One is just because we know that this is out there. We know that people have done studies that tell us this is out there. So even if people don't talk about it, I'm going to presume a chunk of the room is having it because statistically a chunk of the room should be having it. Now in clinic, usually what happens is we finish the visit and then as I'm walking out the door, it goes, by the way, as I'm like leaving, and I'm like, what? Yes. And that's the universal signal for erectile dysfunction. But sometimes the patients will be more upfront about it. Or their partner might. Their partner who brings them to the appointment or is with them may have questions or concerns. There are screening questionnaires, and I brought you all one. Ooh, actually, hey Teresa, under the table in my backpack, if you open it up, there's a thick clipped chunk of questionnaires. Would you mind passing those out? Thank you. Okay, I brought exhibit hall for virtual viewers. Thank you. They're also in the exhibit hall for virtual viewers. So I brought you all one so that if you do feel like this would be hard to talk about, all you have to do is take this self-assessment and just hand it to a provider. They can read it, they will understand what it is you're bringing to them, and it is a perfect starting point for having a conversation. And I have a copy to show you online too. So this is what's getting passed out to you guys. So this is called the MSISQ 19. So this is the MS Intimacy and Sexuality Questionnaire. It's self-administered, and it really helps evaluate for contributors interfering with sexual activity or satisfaction. The limitation to this, or just the thing to know, is there is no established rule of what is a good score or a bad score or what's a problem. It is a problem if you say it is a problem. So if it's a problem for you, it is a problem. If you're cool with where you're at or not having issues, that's fine. But I think this is a great way of documenting kind of where you are and covering some more sensitive topics in a way that might be comfortable for someone who has a hard time talking about some of these things or bringing them up. And it's a way to keep track. So this is free online. It'll be in the virtual exhibit hall. But what you'll see is it's just a series of 19 questions. And at the bottom, there's a scoring to let you know what these questions are really getting at. And it's really lumped into looking at primary, secondary, and tertiary dysfunction. So it's really screening for those three different categories. And really anyone scoring 4s and 5s, which is almost always and always, those are categories that would indicate you're a little more distressed by that symptom, and maybe that is worth discussing. But again, it only matters if it matters to you. This I included on here just because this is another validated questionnaire. This is not one that's easy necessarily to self-administer and score because it's a super convoluted system. But just for you guys to know, like, what exists in the space that asks MS patients about sex, this is like one of the only other ones that's really existing. And it includes like 8 questions. So a lot of our questionnaires really don't include a lot about sex. We also have a research scoring exam, but the sex question is optional. Like, it's not a mandatory part of our scoring system. It's an optional question that you don't have to ask or answer. And usually in the clinical trials, they don't even factor that score in. So I just say that because even like for our assessments, it's such a small piece of everything when it's really such a big piece of our lives, right? Like it's a big part of our lives, but in our clinical assessments, it plays such a small part of that representation. So treatments. So first thing you want to do if the issue is low libido or low sex drive, that's what libido is first just look at the medicines. And fix what might be making things harder. Because there's a good chance that your well-intended healthcare providers are making this harder for you. Very good chance. So, most common meds to know about that are probably making your libido worse. Narcotics. So after a couple months of like narcotics, Testicles get smaller, libido gets lower, so that's a common one. Antidepressants and antipsychotics, I am not advocating that you stop them, but I do think you should know the medications and their side effects. Because if you are taking a lot of guilt about how you are feeling with your libido, I don't think that's fair. I think these medications can have a huge impact. So knowing that and discussing with your provider, are there other options? Are there dose adjustments? Can we work on this? Antispastic. How many people in this room are on baclofen, tizanidine, or some antispastic, right? A lot. Those actually can decrease libido. So that is kind of a catch-22, right? It might treat the spasticity, but it might also be making the libido worse. Blood pressure medicines, bladder medicines, again, might make it easier to prepare for the moment, but maybe making the libido worse. And then anti-seizure medicines, which we use a lot for pain. So a lot of those pain medications can blunt libido. Anybody in here surprised by this list? If you are, make a sound. So other things. You want to stop smoking. I know you hear it all the time, but we're talking about libido now. So if that is important, stop smoking. Alcohol, in moderation, but if your moderation is a lot of moderation, bring it down. Improve diet. Yes, but side note, erection, for an erection to happen, neurologically, all those nerves make changes to bring blood flow into the penis or into the clitoris. If you have bad circulation, you cannot get blood flow into your penis. If you have bad cardiovascular disease, if you have heart disease, if you have bad diabetes, those are things that cause bad circulation. It is really hard to get blood flow into the penis. So if someone comes in and has erectile dysfunction, in addition to neurologic diseases, my first thought is always, do they have microvascular disease? Do they have heart disease? So the whole improving diet and kind of focusing on this, the reason I have a little asterisk there is just a side plug of you want to also think about the fact that this is also a blood flow issue. So you want to make sure that you are living a lifestyle that promotes a heart healthy, neurologically healthy, diet and lifestyle, because really the goal is also to keep that blood flow able to get into the penis. So resistance exercises, we want to build muscle. That's going to help you build testosterone. That's going to help with that libido. Bupropion. So this is an antidepressant that can actually help bolster libido and is sometimes partnered with antidepressants. If those are sort of blocking libido, sometimes this will be given with it to help counteract that effect. If you're premenopausal, and I say premenopausal because that was the group that was studied in the clinical trials, there are 2 medicines for women that are approved for hypoarousal sexual dysfunction, HSDD. I have slides. Fleabhacerin and bremelanotide. And fun fact, a bajillion years ago, I was actually part of the clinical trials for fleabhacerin. But at the time, it was not known exactly how that was going to end up, but it was in the very early stages. And it was a very weird trial, but I got a free MRI and $50. And I was a medical student, so that was, I wanted the $50. And if postmenopausal, sometimes HRT based on the case, or testosterone replacement in some cases. And then lastly, therapy. So pelvic floor therapy, cognitive behavioral therapy. There are many forms of therapy, but sometimes hugely important in part for the libido. So fleabhacerin, this is the little pink pill. So for hypoactive sexual desire disorder in premenopausal women. So this was approved about 10 years ago. How many people have heard of this medication? I see one hand. Any other hands? Been on the market 10 years, people, right? Yeah, most people have not heard of this medicine. It was not, there was a ton of roadblocks like put in the way of this medication. And there was a question of like, for as easy it is for a bajillion Viagras to be on the market, like what was the conspiracy with making it so hard for women to have a medication come to the market? But, so non-hormonal, has effects on some of the different neurotransmitters, and it may help restore a natural desire by helping kind of shut off mental distractions. Because you know how we talked about with orgasm, it's both like activating but also deactivating, like turning off the things that are keeping you away from that pleasure, right? This is sort of helping you shut out the noise and like shutting out some of those distractions, right? When you're like a super busy person and you just have like the weight of the world on your shoulders, it's like, I don't have time for one more thing. I don't have one more spoon left. This might help you let some of that go and maybe let you find a little bit of that desire again. Side effects, kind of like brain fog, lightheadedness kind of stuff. I think you're going to find that possible with any centrally acting medicine. So if it's there, that could be a reason that someone might stop it. If it has not helped by week 12, unlikely to help and would be stopped. Now, bremelanotide, this is also for the same reason, but used a little differently. Approved in 2019. This is a shot taken 45 minutes before sex. You get 8 doses a month. It works on a part of the brain. It's an MC, it's a melanocortin receptor agonist. And it is interesting because there's already a medicine that's a melanocortin agonist on the market that is approved for genetic forms of obesity and hyperphagia. And this is kind of a cousin to that. And so I looked to see if they'd ever considered this for weight loss. And they actually did. They did a small clinical trial looking at this and partnered it with a weight loss medicine, and it actually worked really well. So it's interesting because a lot of these medications all kind of work in the brain around kind of modifying behaviors. But yeah, so this one is interesting. You get 8 doses a month. It is taken about 45 minutes before sex. It can last for up to a couple of days in the body, and can affect sexual function and mood. Site reactions, nausea, skin darkening are potential side effects. You don't see a lot of skin darkening with the daily version, which is the weight loss version. So it's hard for me to say how common skin darkening is with the as needed version. But in general, these medicines are not widely prescribed. There has been very little uptake of these medications. So if the issue is more that there's unpleasant or decreased sensations, one thing that you'll see written a lot is body mapping. So body mapping is this concept of really taking the time to learn your body, your new body. So taking time to really figure out what are the places that are comfortable to touch, not comfortable, what intensity, what speed, and really learn what you like and what you don't like for your partner to then be able to get that information from you. Sometimes topical or topical ointments or lubricants, I'm going. Pain medications, pelvic floor therapy, CBT, stimulators or other oral aids. If you're using toys, though, you want to make sure you have good hygiene or that you're really watching the skin integrity. If someone can't feel and you're using a toy, you want to make sure you're not causing any trauma. If someone has decreased lubrication or ability to get an erection, so for the decreased lubrication, you have a couple of options. Vaginal moisturizers are interesting. It's like a hydrogel that clings to the vaginal wall and will last for a few days. That's different than lubricants, which are like for as needed use. If you're using a lubricant, usually water or silicone is going to be preferable. Oil-based can be irritating and can break down latex. So if you have latex toys that you invested in, they're expensive and you may not want to wreck those with an oil-based lube. And then for boys, erectile treatments. So the top row is your usual, those like Viagra, Cialis, Levitra. There's penile injection therapy, so this can work really well. It's a really tiny needle. And injected into the side of the penis. It can improve blood flow and help with erection. Vacuum devices with a tension ring, but you can't use those more than 30 minutes or not good. And then penis implant, which we do at Memorial. If you did not know Stacy, we do that at Memorial. Stacy's my manager. But make sure it's MRI compatible. So this is a picture of what the injectable looks like. I have one patient who does this, and it is working well for him. So really tiny, relaxes those smooth muscles and opens the blood vessels and helps an erection form. The implant, though, is my favorite. This thing is great. So outpatient, couple of hours, over 90% satisfaction rate. That's amazing statistics. So in the scrotum, there's like an activation switch that you can activate. There's a water reservoir up here. It basically fills these chambers for like as long as you want it filled. And then you can reactivate that switch to deflate it. So works great, and it's on demand as long as you want it. And it's outpatient. Yeah, right? You can clap for that. I think this is awesome. So, one thing to say, they did a trial looking at time to orgasm in people with neurologic dysfunction. And even with neurologic injury and genital numbness, orgasm happened, but on average took up to 26 minutes. It is not that it can't happen. But if you stop at 8 minutes or 10 minutes or 15 minutes because you think it's not going to happen, you may not get there. So the key takeaway for me from this is persistence, right? You have to be okay with sometimes trying longer than maybe you're wanting it to take. But if it's important and you want to work at it, that's okay. In this trial, it took up to 26 minutes, but it happened. And I think knowing that helps, because if you're like, 15 minutes, there's no point, maybe 9 more minutes would have got you there, or 11. 11, yeah. I'm not mathing today. Okay. How many more minutes do I get, or am I done? We'll put it in the panel, because the prosthetic picture was, well, I'll pull them up as we get questions, because the prosthetic was my favorite picture. And then I have notable mentions that I'll slip into the panel. Okay. Like I said, I could talk forever. Okay. I'll save the rest for the panel. Thank you, guys.